we've talked about everything, how to do correctly as a spine surgeon, picking your patients correctly. One of my mentors used to always say the decision's more important than the incision, and everyone's kind of touched base on that. What else is important? Knowing how to do everything. If all else fails, talk to your patient, figure out exactly what you need to do, when to do it. But now you've already picked the right patient, you've gone to the OR, and what are you going to do afterwards? You want to make sure that everything you've learned is correct. So what are the appropriate goals of a spine surgeon? First and foremost, you got to deal with a patient-centric practice, right? Your patient is number one and foremost, so give excellent care. But when are you going to operate? And once you're operating, you need a map, right? So what are you going to find when you're in there? What are you about to get yourself into? When you're perioperatively, we've all talked about making sure you're at the right level. And when you're in the OR, you're like, oh, of course I'm at the right level. Be 100% sure. And if you're not, be 1,000% sure. I have partners, if you've got a weird anatomy, they'll call the radiologist. They'll go down to radiology just to be 100% sure. There's nothing wrong with spending an extra 20 minutes making sure you're right level instead of doing the wrong level and spending a lifetime worrying about that 20 minutes, okay? Is your instrumentation placed correctly? And is everything removed that should be removed? Okay, there's just an article in one of my local newspapers from one of my local institutions. They did an OB procedure and they left a sponge. Worst possible case scenario. And post-operatively, also, everything is correct. How does my construct look? And of course, am I able to sleep at night? So look at this image. What do you guys see there? Looks a little weird, right? Doesn't look like the best construct. But if you look at it carefully, and this is from the 206 area code, so this is local, guys, that's a superimposed image. That's all it is, right? Those screws look like, maybe a first year put it in. Just kidding. First year fellow, like the way Rod taught us. But in all seriousness, it's a superimposed image. So you really have to understand what you're looking at all times. So I came up with a couple of things. So first, you got to be prepared. You got to do all your work beforehand. You got to know what to expect. Do you have the right tools? I don't actually, starting as early in my practice, I actually don't base everything on my office. I call my reps every single case, make sure they have every single thing I need. I don't assume that they're going to have all the tools you need, all the stuff you may need for taking out instrumentation, putting in what you need. Also, what does the spine look like and what are your ultimate goals? We've been talking about this for the past couple of days. Where could I be fooled? And in case of disaster, you never want a disaster, but working at a trauma center, I see a lot of disasters. And one of the ways I've made my niche in the community is I do a lot of revision work. So I see a lot of disasters. So you need an exit strategy at all points. You need to know at what point are you gonna stop and say, we'll come back another day, okay? So, perioperatively, you gotta have your periscope around, okay? Understand your radiology, understand your navigation, okay? Just because you have navigation, it does not mean that everything's gonna go right. Your navigation could be off, okay? A fool with a tool is still a fool, so just remember that, okay? Every single time I use navigation, I find my starting point first, and this is what I teach my residents as well. Always find your starting point, then confirm with navigation, not the other way around, okay? We are not perfect, so I never like accepting, I think it looks okay, okay? Everything needs to look perfect to the best of your abilities, and always, and I talked about this at my station yesterday, make sure you have a good image so you are sure everything looks good. Because you could actually make any pedicle screw look like it's going into a pedicle by changing your x-ray. But if it's not a true x-ray, it's not the appropriate image and it's not true to form, okay? And if all else fails, trust your knowledge in anatomy. So like Dr. Chapman mentioned, I was a resident here. They worked us hard. Thank God for long turnovers, so that's the only time I actually got to sleep. I think Dr. Chapman actually took that picture. So with your post-operative imaging, when, for what do you expect, and what are you gonna do with that imaging, okay? If you're just getting imaging for the sake of imaging, that you're not gonna, if you find something on it and you're not gonna do anything about it, you're just digging your own hole even deeper. So for the rest of this talk, one of my neuroradiology friends from University of Chicago approached me about, I think it's about 5, 6, 7 years ago, about writing a chapter on post-operative imaging, because it's equally as important for us to understand it as they do. So I'm just gonna go through a bunch of slides here quickly. Stop me whenever you want. Just to kind of describe what we should be seeing. So some of the stuff is easy. You've seen your lamies and your hemilamies, right? You've got your complete facetectomies. And these are what you should be seeing post-operatively after you do a good operation on your patient. And here's a pediculectomy. Laminoplasties, which we didn't really discuss much this weekend, but it's an excellent operation with the right indications. And we could probably, Dr. Chapman taught us a beautiful laminoplasty when we were here as fellows, and we could probably talk ad nauseum when and which ones are the right indications. Now over here, this patient had a duroplasty. You're gonna get a call from your friendly neuroradiologist, oh, your patient has some inflammation there. Is it inflammation, or do you have to tell them, no, there's something there that's supposed to be there, okay? Because they're gonna dictate in your note, and in their note, well, there was inflammation, and they ignored it. They have a meningitis. And then, a lawyer, at St. Elsewhere will call you and be like, why didn't you do anything about it? So this is a very interesting case. This was a patient that I saw early in my practice, and then later on, he had a big herniated disc, got a couple of injections, never had an operation. Couple years or 5 years later, had a trauma and had some back pain, so they did an MRI and the disc was gone. So just completely dehydrated, looks good. So it goes to show that sometimes you don't have to rush into an operation necessarily. These discs do and sometimes do disappear. That's not saying that all of them do and we shouldn't be doing operations, but that's just something to keep in the back of our mind. Here's another one that a colleague of mine had. Did a beautiful discectomy, had a little bit of post-operative pain, so they go in there, they're like, get a call in the middle of the night, you herniated a disc. You had a reherniation. Well, he goes, no, I put in some Surgicel there. That's what we're all seeing. So it could remimic something of that sort. Here's just some basic corpectomy cages. We've gone through different types. You've got your fibular strut. Here's a little bit more of a complex mess, to put it politely. And then you've got your stackable cages. And what's important is, especially as residents and fellows, and I did this as a resident and fellow, you've got your list of patients, right? Every single patient is your patient. Look at every single scan as many times as you can, right? Because the important thing is learning to differentiate, learning what's good and bad, and the only way you could do it is by looking at as many of these as possible, okay? Here are some pictures of some different types of bone chips and DBX. Then you could have your osteolysis with some BMP. So now let's talk about ACDFs. Different modalities, you could put in cages, you could put in bone, you could put in iliac crest. Now you've got the 18 different companies that are doing standalones. And of course, the graft subsidence with cord compression, where this now at this point, you have to go back to the OR and do something about it. So some of the stuff you may see as you go through time, some of these things, if you have a more advanced practice at a university, then you could see a lot of these people coming in 20, 30 years later with a lot of these different devices. So you have to understand what devices are and how you're gonna take them out if your attempt is to take them out. Of course, you've got your screws. This is a vantage plate. a lot of hooks that have gone in, and I'm sure a lot of the physicians here still use hooks. These were what Dr. Okonkwo and I were discussing yesterday during my presentation, the facet screws. I honestly have not put one in, but I've taken a bunch out. And of course, you've got your wiring, your Lukey, Harrington rods. There are so many different types out there as I go through. This is kind of a little representative demonstration here of how many there are and how many have been developed throughout the years. And the more time we spend, there's this list in this presentation will only get longer. And of course, we did discuss the vertebral stapling and vector here. So one thing that is very important is understanding what you're getting yourself into if you do revision work and where everything should be. So let's talk about a little bit about interbody fusions. You know, through the years, you could have a femoral graft, you could have your different threaded cages. You know, one other thing that I had to understand throughout the years is which one, if you are gonna do a revision, which ones are you gonna ever attempt to take out versus some that you will never attempt to take out. And some of these cages are almost impossible to take out because they've been so intertwined with the bone that you do not even want to attempt it. So you have to know what your surgical plan is at that point. You've got your different PLIF and TLIF cages. You know, Dr. Askuin will talk about lateral in the next, I think, following my talk. You know, what I taught my residents is always understand, look at the way the cage is going in, and that will clue you in how the approach was the first time. And what I try to tend to do in my practice is when I do a revision, I try to do a different modality if possible, because then I don't necessarily have to go through that scarring. And sometimes it does take a little time off the operative time. Okay? So this is another case. You know, cage was not, I personally, and we'll probably ask the faculty at a later point, I put in at least a screw or something in the front. I don't leave the cages freestanding on my own because something like this can happen. Now this one, I even shudder to think that this operation was ever an operation. The axial lift, I remember when I was a fellow, I spent 5 glorious hours with Dr. Chapman taking one of these out, but I never would like to put one in, and I try to ever avoid seeing them in my office if I can avoid it. And of course, no operation's perfect, including the axial lift, and they have some pseudoarthrosis. So disc arthroplasties, obviously there's many different versions, and we could discuss that at a later point, which one's your favorite and why. And as time goes on, more and more going through. This is probably not the best indication for a skip level disc arthroplasty, and as you could see, that's why. And one of the complications is your arthroplasty actually could turn into a fusion. So you've got a lot of posterior dynamic stabilization devices that have been going through the years. You've got your isobar. You could also have an adjacent level. You've got your X-stop, which again has kind of fallen from tradition nowadays, but there are several other companies that are pursuing that, and I know I've seen a lot of these from my pain management specialists that are putting them in. So not necessarily us in the room, but then you see them in the you see these devices, you see them on your X-rays, your MRIs, and then they come to you after they may have or may not have failed, and you're like, well, now we got to take them out. And this is another spacer. I honestly have never seen it, but obviously they've been put in. Then you've got your Coflex device that is very, very big in Europe and is kind of been gaining some significant traction in the US. But like we've mentioned, no device is perfect, and there's one that has slipped out. And there was a point that we thought we could do dynamic facet replacement devices as well as your dynamic rods. So now let's go to the next portion, which is what could be in my way, right? You're going in, you're like, okay, I'm ready to do this microdisc or this T10 to pelvis. What's in my way? Great, you got a pump in your way. You got to be able to rationalize, how do I get around these pump? Or a spinal cord stimulator. For some odd reason, I've been very lucky. I've had 3 cases in the past 6 months of herniated disc right next to a spinal cord stimulator at the level of the spinal cord stimulator. So that just made that 30-minute operation last a few minutes longer, because if the patient has a spinal cord stimulator, you don't want to displace it, right? And that, you have to start talking to the patient that it could get displaced. My advice that if you are to do something like that, get a pre and a post-op x-ray. Make sure you did not move that spinal cord stimulator, because now you've done a perfect operation for their herniated disc, and all of a sudden they're like, well, doc, you moved my spinal cord stimulator and you never told me about it, and that could lead to another mess. You could also have bone stimulators. Again, these are, I haven't put one in, and I've just seen them in patients. I don't know how long it's been since people are people even doing the implantable ones anymore? I mean, I've just been doing out. So let's talk about what you don't want to talk about, complications, okay? You always have to be honest and cognizant of your complications. You really need to know how to improve yourselves. And yes, you remember all your successes, but I think as you talk to all your colleagues and your mentors in this room, a lot of them will remember their complications more than their successes, because that's how you really move to your next level, and that's how you really learn from what you've done. So you could have recurrent discs, another de novo, post-operative synovial cyst, but then this is what you don't want to see. You don't want to see your hardware loosening, whether it's in your lumbar or cervical spine. You definitely don't want to see a broken screw. It's poor form. This is actually a very interesting complication that I saw when I was a fellow. There was a pretty big CSF leak, and when we closed it, we did it, unfortunately, it was a little bit too tight. So the tight dural closure actually led to a post-op caudate equina, and we actually had to take the patient back and put in a graft. Pseudomeningocele, you definitely don't want to see them, but as long as they're contained, not the biggest deal in the world. Most important, I remember when I was a fellow here, you're going to get CSF leaks, right? Unless you ignore them completely. But if you get a CSF leak, learn how to do a great job closing them, okay?
The fellowship leaks.
Except when the
What's your case, Dave?
except when the fellows finish and you come in. So with that, you have to really understand how to do it and how to treat the complications, right? If you have a leak, sometimes you need to put in a lumbar drain. There's no shame in it. The key is getting the patient better, right? You have to put in a graft. Spend the extra few minutes putting in the graft, okay? And the key to being done, no matter how many times you Valsalva the patient, it's not 100% watertight closure. The most important part is your actual closure and your tissue planes, okay? Everyone flies through the opening, flies through the closure, but knowing a good opening and closure, going through the appropriate tissue planes, you'll be thankful for the rest of your career. Of course, you could have a slip rod, and Dr. Chapman will recognize this case that we did a beautiful revision on a few years ago on. Unfortunately, you could have spinal cord infarcts and epidural hematomas. This case, or any case like this, you're going to see the read will say, or any post-operative scan that you get, the read is going to, what is the read going to say? Can't rule out, right? If the patient has symptoms, just take them back, right? There's no shame in taking someone back, but there is shame for them ending up with a big deficit because of your pride is hurt, okay? Everyone's a family member, as I tell them all, right? Mother, father, sister, brother. Take them back, say, hey, this is what happens. It's one of the things you discuss preoperatively. Take them back and see what you could do. Supraglottic swelling, and then you could have a postoperative discitis, osteomyelitis. All my discitis and osteomyelitis are pre-op because that's the type of practice I have in beautiful Detroit. You can have an epidural abscess as well. And when you do, this is something very important that mostly neurosurgeons don't use, but I've learned here very nicely from my colleagues and Dr. Chapman, is putting it on antibiotic beads, especially if you suspect that you're gonna come back to take them out. So if you know they need another operation, just throw in the beads. Our orthopedic colleagues use it very, very frequently in a lot of their cases, so I typically use that as well. When they say you should go bi or tricortical, it doesn't mean you should grab the aorta or any other vessel in between. Those screws are not the most ideal. What do you think this is over here? It's a drill bit. So, retained drill bit. Who knows what a Gossi fibroma is?
Retained cotton.
Or any retained surgical. So they're, the lawyers have a name for it. So if the lawyers have a name for it, we should probably avoid it. So, you'll see different ways of seeing it. Understanding what it looks like on an MRI is very, very important. All of us here have done some sort of kyphoplasty, try to avoid cement extravasation. And I personally, especially as a younger attending, I get a chest x-ray on 100% of my kyphoplasties in the recovery room just to prove that there's nothing there immediately post-op. Okay, so use your images in all stages, before, during, and after. Understand which image is most useful at what point, okay? Having a good C-arm tech that you train yourself is probably one of the most critical things you could have in the OR. Someone that you could trust, so you're not sitting there going, rainbow this way, rainbow that way. Someone that gets you a shot almost immediately. And if you don't, because it's 3 o'clock in the morning, then you become the responsible one. Make sure you know which way, you're dealing with a 3-dimensional image in a 2-dimensional plane, okay? So understand all that, okay? As residents, fellows, and even as attendings, look at as many images as you can. If unsure, just go get another image. And remember that they don't lie. Those images absolutely don't lie. Don't change the angle of a C-arm just to make your image look good, okay? Unless it's not the correct image. And of course, make the necessary corrections so you could learn from the bad and the ugly as you try to become great. This is the book that I did write for the neurosurgeons. It also includes cranial chapters for the orthopedic, at least the spine chapters. Thank you.
Great job, Mark. Thank you. Thought-compelling things. Rapid-fire questions. First of all, Dr. Hanscom, this was not your case. Get a microphone. Can you pass a microphone to him? Perry, can you give a microphone to Dr. Hanscom? He's behind you. Now wait and see.
I just make a comment. I think that Jens and Roger would agree with that. There's an incredible tendency, if you see something wrong in an x-ray or you have a potential complication, to go into denial, rationalize. And you just gotta, if you think it, do it. And I like Jens to comment on that. You just cannot hesitate. There's rarely a benefit for waiting it out. If you have an imaging thing that's wrong, it is wrong. So Mark's point about believe your imaging, don't screw around, go right after it, because there's almost nothing good happens from waiting.
I would add to that, disclose it to the patient and document it. Never regretted taking a patient back, regretted not taking a patient back. Dr. Jane, who's a common spirit for so many of us here, taught me that, and I try to abide by that also. 3 rapid-fire questions, and then we need to move on. So one thing is biomaterials. PEEK, titanium, allograft. What's your preference? What's the pro and con?
I use allograft in anything more than 1 level at least in my ACDs. Just the way I was taught, and I find my best results. If I do a 1 level, sometimes I'll save bone dust like we used to do here and just fill the PEEK cage.
No, that's the point. PEEK is one of the most overrated biomaterials, I think, in the history of medicine. Cheap to produce, vastly overpriced, has no osseous integration. In fact, it has an anti-osseous integration capability, and at least in its conventional form. And it's really, the radiolucency of it is not helpful for us. It's, with high quality CTs, no problem identifying bone healing on titanium versus allograft. So second thing is post-operative patient in trouble with hardware in there. Should we get a myelogram or is an MRI CT combo preferable? Talk us through that a little bit.
I really think it's dependent on what you're looking for. If you're looking at instrumentation being in the wrong area and you just don't trust what you got in the OR, I would just go straight to a CT. If you're thinking about a epidural hematoma, and this, are we talking immediate post-op or?
Post-op.
Yeah, immediate post-op. The thing is with an immediate post-op, if you're thinking of epidural hematoma, how are you going to get the myelogram? It'll be a little difficult if it's at that level, right? So I would just go straight to an MRI or a CT, or if they have a deficit, just go back and explore at that point.
And pseudomingocele CT myelogram versus MRI, again, does the CT myelogram have an advantage there?
I don't think so necessarily.
Localizing the nidus?
It can, but to be honest, you know where it's going to be if it's a post-op. If it's not a post-op, I do, it's a spontaneous leak, yes, I will do a CT myelogram 100%.
Final question for me, radiologist reports, you see something in their report and it's just in your eyes rubbish, what do you do with that?
That's something, in our times now where it's limited, if it's complete rubbish and I think it's pretty negative towards myself or the patient, I will call them and have a collegial discussion. There's some radiologists that will just sit hard and true, and then I'll just document it in my note. Say, I don't necessarily agree with you.
I want to just emphasize this last point. Professional disagreements are part of our business, but I think you have to read those reports just to know what they said, and then at very least document it in your notes.
And to that point is, I don't actually read the report before I look at the scan. I look at the scan, develop my own opinion, then I go to the report and make sure they agree. They might see something that you don't, right? But at the same time, if it's something completely egregious, call them or just write a note documenting why and perhaps what you would do differently or what you would do.
And just on that note, anomalous levels, meaning transition zone anatomy issues, there's a frequent disagreement as to levels. Any words of advice on that?
Yeah, so this is a very good point. I learned this early in my career. Radiologists count from either bottom to top or top to bottom. Read the report how they're counting. Because if they're counting top to bottom and you're counting bottom to top, you're going to get a complete disagreement. I mean, if you've got like a big fracture, yeah, you're most likely not going to miss it. But if you're talking about a thoracic disc and they're counting down from C2 and you're counting up from the sacrum, you're going to miss it. You're going to be off by a level, maybe 2 levels. The other thing is look at a chest x-ray, especially when you're doing thoracic cases. The ribs could be off too. I had a case where they had 12 ribs on one side, 11 on the other. Right? So if you're not looking accordingly and you're counting up the wrong side, you're still going to be off by a level.
Yeah, I recommend exactly what you said, using the old paradigm of the top, of the first vertebra counting from top down that is non-rib bearing on both sides is L1. So that's the official declaration. But again, there are these hemivertebra that are kind of ambiguous lateral processes. The key thing is you recognize it. The key thing is you use an explanation why you chose what you did. And ideally, you put one sentence down how this differs from the radiologist and why. There's no absolute, but you have to hit the right target level.
One quick thing. Charlotte.
What I also like to do for thoracic discs is use the ultrasound. After you do the laminectomy at one level, you can actually kind of see, based on how you tilt the ultrasound, whether the disc is there or not. So it's actually a good use of.
I use the ultrasound quite frequently, and the other thing that we do at Swedish is used to put in a gold bead at that level preoperatively.
Yeah, you actually published on that with Rod.
Yep.
Speaking of Rod, he's our next lecturer.